Good morning. My name is Dr. Dan Simon. I'm the Chief Clinical and Scientific Officer of University Hospitals and the President of University Hospitals Cleveland Medical Center. I'm joined today by Dr. Eric Beck, the Chief Operating Officer of University Hospitals. Welcome to our friends and supporters. It's great to be back with you again this week. So we're here again today, and I guess my grading system of where we stand needs to come out first. And again, would say cautious optimism, but today we have a flashing yellow light. And we're going to turn to Dr. Beck for that in a moment. But let me give you statistics around the state and then tell you why we're having a little bit of concern within the health system today. So there are 28,454 cases in the state of Ohio, and the 21-day average of daily cases was 578. And that has gone down to 531 in the last 24 hours. Hospitalizations are also down from 84 a day down to 77, and deaths are down from 43 a day in Ohio on the 21-day average down to 32. There has been an increase, however, in intensive care unit admissions across the state. So the reason why that light is flashing yellow is that University Hospitals Health System has 93 cases of COVID right now, which is the highest that we've ever had. So Eric, what exactly is going on that we went from around the 90s before down into the 60s, and now we popped back up to 93? What's happening?
Yeah, good question. So good morning, everyone. Happy to be with you again. What we're seeing in the data is really an increase in acuity of the patients admitted to the hospital, particularly at our Cleveland Medical Center campus. Many of those individuals are coming from inner city neighborhoods, a crescent around sort of the Cleveland municipal area. And we're seeing both an increase in positive cases there indicative of community spread and an increased number of patients that are being admitted to the hospital from that area. The other communities that we track on a daily basis in partnership with our fellow health system neighbors in the community really remain flat or declining. And so that does suggest there isn't broad community spread going on, but rather pocketed activity. Most of the cases that we see continue to be in nursing facilities, congregate living environments, correctional facilities. But we are paying close attention to those inner city neighborhoods in and around Cleveland Medical Center.
Right, and so I think, one of the challenges of this increase to 93 cases is that we're now almost 2 weeks into recovery, and we've had a tremendous increase in pent-up canceled surgery and procedures. But most importantly, what we talked about last time was the deferral of very important health activities related to screening, vaccinations, and then most importantly, chronic disease management of heart conditions, lung conditions, and diabetes. And we're seeing a lot of those patients come back. I mean, I had clinic yesterday and had a lot of patients who called up and said, Dan, it's been too long, I need to see you. And they have deferred their care, and we're seeing that. So great news today at CMC, we're gonna cross the 100 operation barrier today. We typically have a budget of about 113 surgical cases and had been down as low as 30 at the peak of the governor's order for no elective surgeries. And so we're thrilled that we're over 100. But now we're meeting a very interesting balance, which is we're taking care of all the regular business, so to speak. And now we have a little bit of an increase with 39 total COVID patients at CMC. Now these are separated on the COVID wards. Very safe with great personal protection equipment, engineering controls. So there's no crossover into the regular hospital, but the hospital's getting full. So that's the challenge that we're facing now. I think it's a good one to have, but we're gonna have to watch very closely what's happening around the community.
Yeah, I'll underscore that point that Dr. Simon made. University hospitals couldn't be safer, but I do think there's an important story there, which is because many members of our community have deferred care, they're now coming in sicker. So we're actually seeing more patients with decompensated chronic conditions being admitted to our hospitals. And that's really the reason that we are working actively with our patients to bring them back in for the needed care and services that they've deferred. So again, we take great care to, with extra precaution, separate COVID patients from those that are not COVID suspect. And we're in a good place across the system now. About 75% of what we typically see in terms of volumes and activity. Much of that is in person, and when and where folks aren't able to come in person, virtual visits are on the rise as well. So,
you know, one of the things that I did want to mention, as long as we have our friends and supporters on the line, you are obviously very influential in your own families at directing care. There was a very disturbing report out of the state of Michigan that came out yesterday suggesting that vaccination, early childhood vaccination during the past 3 months of the COVID epidemic has caused a drop in vaccination to less than 50%. And in some areas of the state of Michigan, it's as low as 25%. This is getting to the level where epidemiologists in Michigan are worried about potential outbreaks of measles. And so it's really important, those of you who are parents and grandparents who are listening, make sure that the childhood immunizations are up to date and on schedule. We certainly understand how it could have been delayed 4 to 6 weeks, but now's the time to call your pediatrician and make sure that that vaccination schedule gets back on the calendar.
Would encourage you all to talk with your friends and family members in your networks to encourage preventative care, not just for children, but even for primary care for adults and specialist visits. It really is a new scenario we're seeing where folks have foregone care or deferred care, and we're seeing the toll on that.
So Macy, how about some questions for us?
Absolutely. We talked about increase in business. So let's start real quickly just about how University Hospitals is doing financially with the losses that we experienced and bouncing back to solid footing.
I'm happy to take that. You know, so we came out of a tough year last year. We had some one-time special charges that set us back, but we're off to a great start. The first 2 months of the year, as Dr. Simon knows, we had some record volumes. And then we began to respond to COVID in our community. And as such, as we've talked about previously in this forum, we've seen a decline in revenue, a pretty significant hit, as much as 30 and 40% in some areas to our top line. We're now on the backside of that. We're seeing volumes come back. Again, about 75% of where we were before. We're taking careful action to be very mindful of expenses, being very thoughtful about preserving capital, delaying projects that make sense to sit on for now, both because we don't know exactly how things will look post-pandemic, but also to make sure that we're able to continue to sustain our mission very thoughtfully in the community. We stand ready, as do all of our team members, to care for you. And so our financial performance is one of many challenges that we work through every day, but rest assured we're in a great place. We've taken additional steps to mitigate expenses and position ourselves to return as quickly as possible to sort of normal operating volumes.
You know, Macy, I think a lot of people ask me, well, how much is the government helping you right now at the federal level? And certainly we know about the CARES Act, and then there's also the FEMA distribution of funds as part of routine disasters. FEMA covers about 75% of direct expenses related to COVID. And the CARES Act, as many of you know, has different tranches and different levels of funding. And University Hospitals has been a beneficiary of those funds. However, they do not cover you know, the reduction in revenues across the system. It's estimated from the American Hospital Association that hospitals are losing $1.4 billion a day across the country. Hospitals in New York are losing $400 million a month caring for COVID patients, where they have upwards of 1,000 to 1,500 patients census. We have only 93. So we're fortunate in many regards, and we obviously have a strong plan to come out of this, but it's going to take time.
We do have a question about universities beginning to allow students to return to campus to gather their belongings. And of course, there are questions about the fall semester coming up as well. What are your thoughts on getting students are allowing students to travel, driving, staying in hotels, flying, renting a car. Can they safely drop into places like Chicago or Ann Arbor and then get back home?
Yeah, that's a great question. I think we can probably tag team on this one. So I would say two parts. I think the retrieval of belongings for those who went home on spring break and were never able to go back, I think one can safely do that. The risk of going back to an apartment which has been unoccupied with having COVID present is vanishingly low. I think that certainly car travel, which is your own contained environment, is obviously the safest. Flying does expose you to increased risk. Now, the flights are not crowded for the most part at this time. So there have been individuals who, with masking, oftentimes hats and glasses, a lot of wipes for the seats and the tray tables, turning off the air unless you're on a modern plane that has good HEPA filters is a reasonable approach, to be able to go and travel and do that. I think it's a completely different story when we talk about going back to fall semester. And this has been a really hot topic of our Restart program. I was very fortunate, along with Eric and Christine Schmatzer and Bob Salata and Joan Zoltansky, to lead an academic institution WebEx last week, which included Case Western, John Carroll, CSU, CIA, CIM, and some other private schools about just this issue related to returning and having students staying together in a dorm and then going to class. And that's a very complex return process and involves a lot of the things that we've been talking about on our recovery playbook, which is screening, cleaning, and 6 foot in between applied to a college setting. So it's a variety of screening questions, daily temperatures when one's walking into dorms or into classrooms. It's redesigning classrooms, incorporating dual learning. So you can't have a 250 to 500 person lecture hall with 6 foot in between everybody. So that could be an online experience, but then the smaller classes and then breakouts with graduate students and advisors could very well be in person. Cafeterias are going to need to be grab and go. Roommates are going to become your sort of self-quarantine family. Wild fraternity and sorority parties are going to be off limits. There's going to have to be a lot of social controls. And as best we can tell right now, live sports are unlikely. They may only be for the participants. So I don't know, Eric, if you want to comment. We had almost a 2-hour session with the colleges, so a lot of ground to cover.
Yeah, you covered a fair amount of it. I would add a couple of pieces just as reminders. We need to always put risk into context, and for folks who are otherwise healthy, that risk is lower. If you have chronic conditions, that puts you at increased risk. The fundamentals regarding hand hygiene, trying to remain as touch-free as possible in these activities, thinking about class size or size of gathering, air circulation, also key considerations. And then, as Dan said, a lot of hybridized strategies, reinventing the experience, trying to get back to some degree of normalcy. But we've seen the spectrum of strategies being employed both by institutions of higher learning as well as by high schools. And then a whole unique set of challenges with elementary school and early childhood education, in which their ability to be reliable historians, to follow instructions, to adhere to masking and other things are a little bit more unique in terms of the challenge. And so we're awaiting anxiously additional guidance from ODH in the state so we can understand their perspective. And we'll stand ready to support each of you and our community and our organizational partners to interpret that and apply that so that we can get back to normal as safely as possible.
You know, it seems, Macy, like there are 3 colleges that we're hearing a lot about who seem to be on the leading edge of this. Notre Dame announced their plan yesterday. Brown and Purdue have very well developed plans, and these are very creative. They involve the students coming back early in mid-August and finishing their semester at Thanksgiving break, so they don't come back with the issue of traveling and then reinventing sort of this quarantining period. And so that's pretty clever. It's going to require students to get back at it a little bit earlier. But I think for the most part, since I have a son who's a sophomore, getting back in August looks pretty good right now, as opposed to staying with their parents for another semester. So I think we'll stay tuned to Purdue and Brown and Notre Dame and see what the response is of other college presidents to those plans that have been put forward.
Speaking of wild parties, they weren't frat parties, but we do have someone asking if you were concerned about the large crowds at bars and restaurants across the state over the weekend.
Well, I'll start. In a prior life, I served as the medical director for the city of Chicago, and can tell you that anytime you try to put in place these sort of interventions, they always run the reality check of being interpreted on the front line. And certainly we've seen examples of unbelievable precaution, discipline, and restraint exercise. We've also seen examples in which that's quickly decompensated into large gatherings. Adhering to not only the spirit of the guidelines, but really trying to understand how to minimize the risk of aerosolization, minimize contact with surfaces that can harbor COVID and other germs, is really the name of the game. And so just like everything in COVID, this is a learning journey. And so we need to continue to support each other in how we learn and adapt quickly to applying these guidelines. And inevitably there will be fumbles, and we need to learn from those quickly and support organizations so that we can get back to normal as safely as possible. But when and where there are these examples of shall we say, less discretion, we need to call that out and encourage adherence to the recommendations. Dan, what are your thoughts?
Well, I really was just shocked by what happened in South Korea last week. And that was one individual, as they opened the bars in Seoul, went to 5 bars Friday and Saturday night, and using very clever cell phone triangulation and contact tracing. Perhaps Kim can put up the box it in slide. No one's better at contact tracing than the South Koreans. They discovered that this one individual over 2 nights in 5 bars interacted with 5,000 people that needed to be tested. And that testing resulted in only about 2,200 people apparently showing up. And of those 2,200 that showed up, so far, this one individual infected 168 individuals so far that we know by going to these 5 bars. So there is no question that this box-it-in strategy is going to be required as we open up bars and restaurants, because there are going to be individuals, despite the signs that say, if you have cough or upper respiratory tract infection or fever, please don't come into the establishment. They do it anyway. And so Dr. Frieden and the box-it-in strategy that you see on the screen identified the fact that we need to test these individuals. We need to isolate them. We have to find out who they are, and then we have to quarantine. And it's really this contact tracing that allows you to very rapidly determine if somebody turns positive, who do we need to remove out so we don't spread. And it's just remarkable when we think about COVID. We talked about that R value of how many people does one person infect, and it was around 3 as an average, and you need to get below 1 to control a pandemic. And here's one person who spread it to 168 people. I mean, it's shocking. And so I have to tell you, I think that if you're going to go out right now, you need to go environments that are safe. And that would be physical distancing of 6 feet, engineering controls, which is a lot of plexiglass or screens between tables. And it better be really worth it to go and have that drink instead of having it at home if you want to risk what happened in Seoul. And I have to say, and this is really a serious matter, we do not have the contact tracing apparatus set up yet. The governor is committed to hiring 2,500 individuals to do that. We're very fortunate that we had a terrific volunteer group, the Case Western Reserve University Physiology Brigade, as they call themselves, are 150 medical students and graduate students who've been trained in contact tracing and interviewing, and obviously they're at the disposal now of university hospitals to be able to help us contact trace. But we don't have the system set up yet that they have in South Korea. So I'd be a little nervous, Macy, about, for instance, recommending that your daughter goes to out, to meet friends at a bar this weekend. I think that's a little bit tricky.
I'll be sharing that with her since she, would not listen to me if I were saying that. So I need a copy of this, please, somehow. Let's talk about all eyes being on the vaccine. Specifically, let's talk about Moderna. What are your observations on the speed of how this is happening?
That's a terrific question. We were talking before we went on about the vaccine. So a couple of things that we mentioned before. So the world record for a vaccine is mumps in the late 60s, which was 4 years. Think about that, 4 years. And we now have two vaccine leaders, the Jenner Institute in Oxford and Moderna in the US, that are actually using a similar strategy. And it's a strategy that's never been used in a human vaccine before, which is an RNA strategy. So instead of giving an inactivated virus or a protein of the virus to make an antibody response, they're giving the RNA, and those of you who did high school biology, as you know, it's DNA to RNA to protein. They're just giving you the RNA, you make the protein in your body, and then you make the antibodies to it. So it turns out that what we know from the Jenner-Oxford vaccine is that you make high titer IgG antibodies. If you take out those antibodies, they do neutralize viral infection in vitro in the test tube. If you give that vaccine to non-human primates, they were 100% protected from a COVID infection. And now the Jenner Institute is vaccinating 6,500 individuals in the UK with the results of that trial expected by the end of July, with a goal that they are now making 3 million vaccines available in September. And we heard last night, 30 million restricted to the United Kingdom by the end of the year. So that raises a very interesting issue, which is, are these now sort of national treasures, and will the vaccine be shared widely across the globe? And it's raising very interesting questions. AstraZeneca purchased the vaccine from Oxford and is committed to global manufacturing, both in India, in China, and the United States. And it is said that the vaccine may be more widely available to high-risk individuals, so the elderly and those with pre-existing conditions, as well as healthcare workers, potentially by the end of the year. The Moderna vaccine, as everybody has heard, also reported that in a very small number of patients, we have to highlight that, 8 patients in the 25 microgram dose cohort of the RNA developed a high titer of neutralizing antibodies that would be predicted to prevent infection. So that's very exciting. They had planned 25, 50, 100, and a 250 microgram dose escalation, and now they're going to move forward with the lower doses in a larger trial, and are also suggesting the possibility that they could have a vaccine ready by the end of the year. And so that's really exciting and would be a land record, because it would be in 12 months instead of 4 years for mumps.
Wow.
But, I think Dr. Fauci's 12 to 16 month time window, may be more reasonable when you think about the fact that we have probably 3 to 6 billion people in the world who want the vaccine. And the question is, who's going to get it and in what order? I think in the United States, there's no question that healthcare workers, first responders, and high-risk groups are going to be first out of the gate, and then thereafter the general population. So I'm kind of excited, I have to say, but I'm also realistic for when it actually gets to Cleveland, Ohio.
Yeah, it's heartening and certainly something that's optimistic from a horizon perspective.
We have a question about the modules that came out with 10,000 cases per day in Ohio, as much as 5,100 patients here at UH alone. So these were done during the stay-at-home order with already in place. How were these modules so wrong?
The modeling, yeah, it's an interesting exercise. So modeling is a science that's really all predicated on an understanding of how the virus is transmitted. That contact tracing that Dr. Simon referenced before really helps to understand the behavior of the model. It also rests on the assumptions that go into those models. And the assumptions that went into our models were initially inconsistent with things that were seen early on in the pandemic. Again, some of that likely attributed to a variety of interventions taken by all of us, by our governor, but also by the health status of the communities who were affected. So none of the models contemplated congregate living or the inability to have community spread mitigated inside of dense housing environments like nursing homes or correctional facilities, et cetera. And so the expression of the pandemic here has really manifested itself differently than those models contemplated. Having said that, all the models have course corrected, have revised their assumptions, whether it's the IHME or the OSU model. There's probably 3 or 4 others that are worth noting, including the CDC flu surge, the Cuventus. All of these models now have taken into account better data, better assumptions, and a more contemporary understanding through contact tracing. And so they're all now much more in line. And so better that they erred on the side of having us over-prepared as opposed to under-prepared. But you know, again, the next unknown is, will there be a second surge? What does that look like? And how long will this persist prior to a vaccine being available?
You know, Macy, I think Eric touched on a really important point, which is most of those models assumed a physical distancing, you know, compliance of about 20%. And Ohio, you know, shattered that and got down to almost a 60% compliance with the governor and Dr. Acton's orders. And that's really what worked here. I mean, I think that, you know, you could argue we're in different geographic areas, but if you look at 2 places that didn't do this that are very close by, Michigan and our former home of Chicago, it's really a tale of different cities. It is. You know, Michigan has been overwhelmed, a population that's much less than Ohio and probably 3 times the burden of disease, with hospitals that were overwhelmed with their capacity. And Chicago also very different. And so it isn't, you know, the latitude or the longitude, the temperature, the weather or anything. This was just the ability to have a governor that shut things down much earlier than those, social distancing, stay-at-home orders. And that was about a 3 to 4 week difference. And that's probably what made this ultimate difference for us. And we're very fortunate to have such strong leaders.
Diane has a question about whether UH is exploring the use of any supplemental alternative modalities. And this might be a good opportunity to talk about some of the fascinating proposals that are being developed through HDI.
Right. So, well, innovations for treatment, you know, UH, I got to say, is really on the forefront. And it's been just amazing to watch Dr. Grace McCompsey and her clinical research team bring in new protocols. So since we talked last, we've now enrolled 4 patients in our stem cell trial from Athersys. This is the concept that mesenchymal stem cells are immunomodulatory and dampen that inflammation that causes that overwhelming lung disease. And we treated the first patient in the US in that trial and have now treated 4 patients, which I think is great. We've enrolled a total of 93 patients in the remdesivir trial, which is the antiviral therapeutic that we know is efficacious against COVID. But unfortunately, that trial is coming to a close by the end of May. So we have all the drug on hand for that trial that we were allowed. And then when we use it up, which will be about 100 patients, we're only going to be able to use the drug that's available on a compassionate basis through the emergency use authorization. And unfortunately, Ohio has been allocated a very small number of treatments that was distributed, as you recall, 150,000 patients worth of free drug by Gilead was distributed across the country based on how many patients you're taking care of. And so it turns out that UH will only receive enough drug to probably treat about 40 patients. So it's better than nothing, but it's very frustrating when we will have treated up to 100 patients in the trial. We also have new anti-inflammatory drugs that we've talked about, tocilizumab from Roche, which is an antibody to one of those inflammatory proteins that just sets off the body into a really bad reaction. And we've been treating patients with that. I think what, Macy, you're referring to is the tremendous call for new science and new innovation related to COVID that was done by Dr. Jonathan Stamler in the Harrington Discovery Institute. And it was a call across the United States and the UK. And we received 265 proposals, really incredible, for new vaccine technology, new antivirals, and new anti-inflammatory therapeutics. And that list has been whittled down. Poor Jonathan Stamler and Mukesh Jain have been on Zoom calls with their team, going from 265 applications down to 50 applications, you know, just hundreds of hours to get the best of the best. And then from those 50, leading pharma experts and virology experts are going to choose the 10 that we're going to fund for the leading therapies, both vaccines and antiviral. So I think UH is on that cutting edge. We have real therapies for patients. One of the good ones that we now have, which we've been talking about, is the convalescent plasma. So this is taking the plasma from patients who are 28 days from recovered from their infection. They have those protective antibodies, and we give them to patients who are very sick in the ICU. We have 8 units of plasma already in the hospital. We're screening and enrolling patients for that right now, and suspect that this will give us another tool in the holster for our sickest patients, which is important. We have about 36 ICU patients across the system last night who need these type of therapies to prevent long days on the ventilator. And as we know already, the average ventilator time of a COVID pneumonia patient is nearly 14 days. It's 4 times longer than a non-COVID pneumonia patient. So we need everything that we can get. So we have the therapies, and we just hope that the number of cases will go down so that we won't have to use them.
A lot of promise on that front in terms of the science and certainly in terms of the care, but UH is equally as innovative in the non-care dimension of this COVID pandemic, specifically partnerships with Magnet around manufacturing PPE and an innovative testing booth that we've deployed in some high-risk neighborhoods. Very interesting. You've probably seen that in the press. Similarly, a partnership with Eaton Corporation, manufacturing a touchless door opener that we're going to be rolling out here. So some really innovative things going on out of UH in partnership with our local neighbors. So would be remiss not to sort of applaud UH's national leadership position in innovation during this pandemic. It's really remarkable.
There are a lot of developments with testing modalities, particularly Abbott's. Could we touch on that a little bit?
Yeah, this is a really difficult and sort of disappointing turn of events, which is the Abbott rapid test, which many of us have been talking about. It's a point of care instrument, sort of the size of a toaster oven, that allows us to get a viral PCR-like result within 15 minutes. And we've deployed them in the emergency rooms and in other areas to test if patients are COVID positive or negative. I'm sure many of you have heard about the fact that the White House, for instance, tests the president and the vice president virtually every day with the Abbott rapid test. Well, Abbott reported last evening that they will no longer stand by a negative test result alone, that it is used for patients who have high degree of viral shedding, who are symptomatic. And in that instance, a positive test is useful to designate them as positive. But if they're negative, they could be a low viral shedder below the sensitivity of the Abbott test, which means that you need a second traditional viral PCR test that takes hours. And so what it really means is that applying the test to asymptomatic individuals, like saying We're going to test the leadership of a very important corporation every day to make sure the CEO doesn't have COVID is an inappropriate use of that test. It won't pick up those patients who are actually, those individuals who are asymptomatic and potentially shedding. That has created an operational nightmare for us in the last 24 hours. And maybe, Eric, you want to explain, how did we get out of this? Because everything was based on using 1,900 of these a week.
So great question. Thanks for the softball, Dan. To answer the question, there's a concept in diagnostic medicine called pretest probability. And as you heard from Dr. Simon, really applying the Abbott test to the right types of patients with the right pretest probability, it's still very useful to us. It's really the subset who are asymptomatic, who that test is not going to be a reliable data point for. So the good news is, under the leadership of Dr. Christine Schmatzer and our entire laboratory medicine and pathology team, we have cultivated numerous methodologies for testing. And so we're fortunate, as we've ramped testing capacity, we can now take those patients with lower pretest probability, the asymptomatic patients, and put them into a different workflow to support that. Of course, we're working to get all patients the care they need, particularly those with procedures or surgeries who we do pre-procedural testing on. And so we're continuing to dynamically match those different testing methodologies to the right types of patient populations so that we're not only confident in the results that we're giving you, we're keeping everyone safe, and we're also continuing to support all the testing capacity that's required. As Dr. Simon said, it does mean that, again, those asymptomatic routine type of screening scenarios for COVID really are still the lowest priority. And with testing capacity on the rise, we need to continue to focus what is available around those higher risk groups. So again, focusing on those that are admitted to hospitals, those that are in the congregate living facilities that we're trying to help support and contain the transmission in that setting. And then, of course, patients who are having symptoms or those that require pre-procedural or pre-surgical testing. So the good news is that's a complex matching exercise from a logistics team, but as we've proven time and time again over the past several months with this pandemic, UH really has had flawless execution from a logistics and an operational standpoint. So troubling news, disappointing news, but we're an agile organization that can respond to those changes and continue to support the needs of our community.
You know, the one thing, Macy, a lot of people ask is, how common is it to be an asymptomatic carrier of COVID? And we've learned a lot in the last 2 weeks testing all the people who are scheduled for surgery or invasive procedures. And that rate, using the most sensitive, hour-long viral PCR test, is probably less than 0.5%. So it's very low. So about 1 in 200 individuals are an asymptomatic carrier, as best we can tell. That's a lot lower than people thought. And in fact, many people are now wondering that if it is only 1 in 200, why are we continuing to test everybody every day who's undergoing surgical procedures? And in children, it's even lower.
It is.
It's less than 0.2 to 0.3%. It's more like 1 in 500 of children. And yet every day at Rainbow, everybody who's going through surgery, dental procedures is having a COVID test for safety. So we're erring right now on the side of safety. We want to know what the individual has. And most importantly, we're protecting all the nurses and anesthesiologists and doctors and other patients who are coming in contact with them. So we're going to continue to do that, but it's very, very low.
I'm going to lump a couple of getting back to normal questions. What are your thoughts about hair salons? And you've already talked about bars. What are your thoughts about outdoor dining?
Well, I'll start. I need a haircut, hoping to get one this week. I think it's safe if all the best practices are employed, which is, when and where you can avoid lines or queuing, 6 feet in between, rigorous cleaning practices, as you've heard, focusing on employing the right masking practices, and trying to limit total occupancy. Those are all, coupled with the foundational hand hygiene practices we continue to underscore, are really going to keep you safe. Obviously, your risk is higher if you have underlying chronic disease, and that needs to be put in context. The best person to do that for you or with you is with your physician or your provider. Having said that, outdoor dining, again, is actually safe if all of those practices are employed. So having tables 6 feet apart, but then people around a table that are in close proximity, is not the intent. The goal is really 6 feet between all persons and parties. So thinking about larger table spaces, thinking about avoiding sharing or passing of common tableware. Those are the types of things that help to reduce the risk. And then, lastly, I would say that, choosing an establishment that takes safety seriously is really, something that you should put some time and attention into. Inquire about what they're doing to manage those. And some of the higher risk areas there are really in the transaction related with payment, in which you may have credit cards or touchable surfaces like keypads and pens for signatures, et cetera. Think about all those sort of minor, seemingly innocent activities that can actually be the highest risk, even if you're appropriately spaced and masked in the facility. Dan, thoughts?
Well, I think you hit it all on the head there. I think, as I go out now and see, as I pick up food, because I haven't gone to any patios yet, you do see establishments that take this very, very seriously. They want you in the car. They want you to call. When they deliver the food, there's absolutely no interaction. The credit card is over the phone. It goes in the trunk, and you're touching the button to put the trunk up and down. So it's really a no-touch interchange. And then the food goes up to 180 degrees at home. So there's no virus, even if there was any virus. So I think that I agree with you completely. Establishments, clubs, and things that take employee safety, customer or member safety seriously and communicate that clearly are the ones that I think you can trust and be able to do that. But I think it's going to be a slow recovery for some of these establishments, because I don't think people are necessarily going to be running, to indoor restaurants at this time.
One of our guests is concerned and is looking for some encouragement. She has a 31-year-old healthy daughter. She is in a retail position. They are doing all the right things at work, but the customers don't always do the right things, and there is no plexiglass at this moment. So she says, can you give me some encouraging news about the outcome for my healthy 31-year-old daughter? No pre-existing conditions, but if she should contract this virus, the mother's very concerned.
Well, to start, again, it's about putting risk in context. There's no single bullet. All the things that we describe collectively and together confer the greatest protection and safety. But just like when you get in your car and you're driving on the freeway, while you may be following all the rules and wearing your seatbelt and operating your vehicle safely, other people may not. And while we can't control that, we can take additional precautions. So when and where we see people in public spaces that aren't adhering to the rules, don't be bashful about calling them out in a respectful way. And certainly don't be bashful about stepping aside or trying to avoid close contact or proximity with those folks. Obviously, when and where we think about high-risk surfaces, you can continue to defend yourself by frequent hand hygiene, in certain cases, high-risk scenarios, wearing gloves, if that makes sense, et cetera. But an otherwise healthy 30-year-old female is lower risk by demographic, and with the right precautions and the gumption to call out when rules aren't being followed, can go a long way to add some additional layering. Dan, what are your thoughts?
Well, I think that the customers can be pretty influential. I think about, walking into Heinen's, and my wife and I commented initially that Heinen's was wholly unprepared for COVID. It was only over time that plexiglass, think about the interaction between the cashier and the customer. Mm-hmm. That is a prolonged interaction time without 6 feet. And of course, now there's complete plexiglass. They were not masking or face shielding, and now they are. And I think there is an expectation of many retailers, and I've seen them because I've gone by more so out of support to some friends who own retail establishments, just to say, hey, I'm glad you're back in the game. I hope it goes well for you today. But there's a clear sign at the door that says, you need to wear a mask if you're coming into our store. And I think that that is, a very important protection. It protects the customer wearing the mask, and it protects others as well. And so I agree with you completely. You have to, she needs to stand up for her safety. In most retail establishments with that kind of contact, you would expect some plexiglass barrier if people are not masked. And, as they say, a typical barrier that we use in the hospital between a reception desk is about $200. So it's a small investment for the safety of your employees.
So we mentioned our numbers here at UH at 93. Cuyahoga County mentioned that they are seeing more spread from workplaces that have reopened. Are we seeing this in our admissions?
So again, many of those folks are otherwise healthy, don't manifest illness that would require hospitalization. So again, we see typically the sicker subset of those patients, those who are otherwise able to safely weather out the illness at home, don't present to the hospital. And so when I think about data like what was described, I try to frame that around who do we typically see at UH in our hospitals versus who's talking to their primary care physician, for example, and sort of waiting things out at home. I will say the data overwhelmingly across the 21 counties that UH services primarily does not show an uptick in community spread. And that is, cautiously optimistic. But then we do see pockets, certainly in the congregate living facilities, and again, as I mentioned, in some specific neighborhoods that for a variety of reasons, either high density housing or a higher vulnerability by underlying disease, social determinants, et cetera, are at higher risk, and we do see community spread there. So I can't speak specifically to the retail. Dan, I don't know if you have thoughts on how to interpret that.
I actually, Macy, I really don't have any knowledge yet about what is the infection spread related to this early phased opening in retail. I just don't know. All
right. Let's talk a little bit about, well, I should know it. I've said it 100 times. It's just misspelled here, hydroxychloroquine. Thank you very much. So in Texas, there was some reports that patients were not able to get that. So they want to know what's happening here. Are patients who are only hospitalized to getting it? Do you know of any pharmacies restricting this drug? What's happening here in Cleveland?
Right. So, we feel pretty strongly that this drug should only be used in the context of a clinical trial, because the overwhelming data so far is that there is very minimal effectiveness at treating a COVID-related viral pneumonia and hospitalization. It's been tested in the moderate to severe populations in the US with no improvement in outcomes. And in fact, evidence, especially in studies from Mount Sinai and others in New York, that the arrhythmic complications of prolonging the QT interval is leading to heart problems with the drug, especially in the combination of hydroxychloroquine and azithromycin. So there are restrictions of use in the state of Ohio for hydroxychloroquine. It can only be used right now in patients who have an established indication for use. It's used as an immunosuppressive agent to treat arthritis like rheumatoid arthritis or lupus and other conditions like that. And if you had a pre-existing condition, you can continue to get it. You cannot get it in the UH health system for COVID unless you're enrolled in a trial. And so it is restricted, and I think it should be because there are dangers in using it, and the efficacy is, the evidence for that is very limited at this time.
Yeah, just to underscore Dr. Simon's point, because of that risk, the State Board of Pharmacy has issued a variety of surveillance activity around this. And inside of UH, Dr. Simon and I, in partnership with our other clinical leaders, have both put restrictions in place from a prescribing perspective, as well as from a dispensing perspective on all UH pharmacies. So that is our position, and it's really about safety.
So is it safe to send kids to daycare and camp? And what about pools?
So that's a great question. I think we have to take those separately. Daycare is a different issue. and the governor will be releasing more formal recommendations on daycare, and has said, of course, that there are situations in which it's necessary for a family because of two working parents who have no other alternative. But he did, I understand, say in one of his press conferences that if he had the option, he would not send, for instance, his grandchild to daycare. So daycare is complex, and a lot of it has to do with the fact of how many caregivers there are to how many babies that are in daycare or young children. In terms of day camps and swimming pools, this is a big question. And as you know, the governor's guidance said that swimming pools and day camps can open. Swimming pools, I believe, on May 26th, interesting, after Memorial Day weekend, so it opens on Tuesday. And I think that we have advised and counseled a variety of clubs have called us about swimming pools, and we've said that occupancy rules need to be followed, so 50% or reduced occupancy most likely. Believe it or not, we think it's likely that you'll need pool reservations because families are going to be dying to get out, and the pools cannot be crowded 6 feet in between. Maybe families can have their chairs together, but non-related families will need to be 6 feet apart, and there'll need to be control of the crowds and the intermingling of that. I don't think there's a risk for coronavirus spread in the swimming pool. The respiratory and the droplets are really the main spread. It's really outside of the pool, and that's why the pool deck configuration becomes very important. I think the governor has a sports commission. Our own Dr. James Voos, who's the head physician of the Browns, is on the sports commission. So right now, for all of our listeners, the most important one is, yes, you can play golf. So all of our golfers out there want to know that, and those restrictions are pretty clear about carts and not touching clubs, and if caddies are involved, they're only doing distance and reading the green, they're not handling the clubs. Softball, baseball comes alive on the 26th. Tennis, good for me, as we always say, comes on the 26th, but they're very complex rules about how many cans of balls you're supposed to use. I think the big question, of course, in Ohio is football. What happens to Ohio State and what happens to the Browns? And that's exactly why Dr. Voos is on the Governor's Sports Commission. We do not know the outcome of those meetings that they have. They've assembled these experts to figure out, how do you get to soccer and football? And we don't know yet. I think that there's a lot of hope that maybe you could, but it's going to involve some very complicated testing strategies. I would think if you listen to the NBA and Major League Baseball and what we've heard about professional football, they're talking about testing every 3 days. So we'll find out from Dr. Voos, and maybe it'll be a good guy to get down here one day and talk to us about when we can send our children and grandchildren to play soccer and football, and when we can watch it on TV.
I would just add, as you think about resuming those activities, agree with everything Dr. Simon just summarized. The higher risk aspects there are locker rooms, changing facilities. So if you can avoid having to spend time in there, or, spending no time in there, avoiding touching those surfaces, high opportunity to improve the safety. Golf, no shotgun starts, I think I was reading. But overall, I think if you take the right precautions to reduce occupancy, you're safe. And actually was just reviewing some literature this morning on the pool issue. Most of the state regs regarding pool sanitation provide even additional protection beyond just the unlikely transmission via water. So probably pretty safe all the way around if you follow the best practices.
It's interesting that you mentioned that, Dr. Beck, because he is the lead researcher on a study that we just completed last year on germs and bacteria in athletic training rooms. So he was quoted in the New York Times. If anybody wants to look up that article, it was just last week, and he's going to be on Fox 8 tomorrow, actually talking about re-entering sports. So he's in very high demand right now.
Yes,
I think at the end of the day, you're not going to be able to make everyone happy with this. But it's the new norm, correct? So as we're getting toward the last few minutes of this, could we go back to the fact that we are seeing higher numbers? We are operating on more patients, we're getting back to business, and the fact that we are going to be able to continue to do both of those in the foreseeable future with enough PPE?
Yeah, well, I'm happy to start. So Dr. Simon and I participate in twice daily calls in which we review our supply chain forecast. We've built deep logistics expertise, as I've commented on previously, in which we then test that forecast against a range of assumptions in which we consume more PPE, we consume less. We've done a fair amount of work under the leadership of Sean Osborne and a number of other supply chain leaders to diversify our sourcing channels, including some new partnerships that you'll hear more about in the coming days, which adds more durability. Certainly, supply chain has come into focus in healthcare in ways it never had before, but we're in a good place. And because of the swift action of Governor DeWine and Dr. Acton, thanks to all of you and our neighbors for flattening the curve, that bought us time to deepen our inventory of PPE, and we're in really good shape. And that means we're able to get back to taking care of you, and we're able to continue to respond where needed in the pandemic.
All right, so we've got just a couple of minutes if you would like to wrap up with your final statements for our guests.
Sure. Well, I just like to say thanks again. It's a pleasure to kind of get out of the day-to-day and talk with you all virtually. In admiration for your continued support of our mission as we sustain our work in the community, both around the pandemic response and in getting back to caring for our community. We're incredibly grateful for your support and generosity. So thanks.
You know, I think, Macy, what I would just like to wrap up with is just to let our friends and supporters know how important their generosity has been during this time. You know, we still have many, many care workers on the front line, both in the COVID regular floors, the COVID intensive care units, and in the emergency room. And all of your support through the COVID Caregiver Fund has been critical in providing meals, PPE protection, engineering controls that are really going to make their workplace safer and to provide them with relief in special areas of comfort and to be able to remove themselves from these stressful environments. At the same time, we also want to thank you very much for your support of the COVID Community Fund, which has really been focused on these great research efforts. One of the things that we didn't talk about today, Macy, was this whole antibody testing effort. And we have decided to go with the Abbott antibody platform. It has a 95% sensitivity and specificity. And this very week, we're starting our 10,000 healthcare worker frontline provider testing of antibody. And you know, I think Eric and I eventually will be asked to give blood to that because we have been exposed to those types of patients. They want to find out. This is part of a study. This study has been supported by our friends and supporters. There is about a $25 expense per antibody test. We want to eventually do all 28,000 healthcare workers in addition to wider testing in the community. So I just want to thank all of you. Your texts, emails, and phone calls have really been great. So thank you. As soon as we get to the Veterans football,